Immunotherapy in renal cell carcinoma. My name is Kai Jimenez. Definition. Renal cell carcinoma is a third type of urologic cancer and has a poor prognosis with 30% of metastatic patients at diagnosis. The antiogenics and target immunotherapies led to treatment remodeling emphasizing the role of the tumor microenvironment. Immunotherapy is defined as excluding cancer by activating the autoimmune response against the tumor, rather than attacking the tumor directly.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months. Compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Applications in medicine. Immunotherapy can induce long-lasting anti-cancer responses owing to the generation of antigen-specific immune memory, either through memory T cells or antibodies. Several crucial steps are needed to the mount of initial effective immune response against tumors.
So the next wave is these checkpoint inhibitors. There's at least 4 or 5 trials that I know of. I think only one with atezolizumab that's actually up and running. Others with nivolumab and durvalumab, and also, any drug you can imagine will be tested in that setting. It probably makes a lot more sense. It's going to be better tolerated for patients, I think. I think probably has the potential to extend overall survival, which would be ideal, which we haven't done to date, even with S-Tract. And so we'll have those results in many years, but I think probably if we're sitting here in 5 to 10 years, we'll be talking about those drugs as standard of care.
Pros and cons. Pros. Wide adaptability, the treatment can control and kill multiple types of tumors. Cons. A variety of non-specific toxic and side effects may occur after using some patients, and even hyperprogressive disease may occur, accelerating the death of patients.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. Doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease, or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Issue applied in Ecuador. Clear cell renal carcinoma is the most common of kidney cancers. At the time of diagnosis, 30% of patients present metastasis and 40% are in recurrence of the disease. It is highly resistant to chemotherapy treatment, and poor response have been shown with previously used interleukins and interferon, which is why currently targeted therapy with tyrosine kinase inhibitors are used.
I think it's a truly exciting time. I mean, bladder cancer has been pretty much neglected for decades. We only had cytotoxic chemotherapy that had some modest efficacy, I would say, in patients, and now we are witnessing a true revolution with the approval of 5 immunotherapies. We're still, I think, working our way through in how to best identify patients who may benefit from these therapies and how to improve these therapies. But I think we are witnessing very durable responses in a subset of patients who can benefit from these therapies for years with really sometimes minimal side effects. I think this is truly gratifying for any medical oncologist. So kidney cancer has always been kind of like a immune responsive tumor. It's really the only other cancer where we have essentially old-fashioned immunotherapy a la high-dose interleukin-2, similar to what we use in melanoma, approved with long-term benefits. So since November 2015, we have nivolumab approved, a PD-1 inhibitor, and we do know that we can induce very durable responses in a small subset of patients, around 21% of patients. However, simply speaking, it's not enough. And I think the future is going to be to look at combination therapies. This will come forward in the short term, I would say, in 2 different flavors. One is the combination with VEGF inhibitors, and the other one in combination with another immune checkpoint inhibitor called CTLA-4 inhibitor, or Yervoy. And I think we will witness in a very short amount of time how the first-line therapy for kidney cancer is going to be transformed. It's going to be driven by immunotherapy, truly.
Conclusion. Renal cell carcinoma include distinct entities with specific molecular alterations. Encouraging results have been obtained in the treatment trials of various malignant tumors and improve the efficacy of immunotherapy and reduce adverse reactions by finding new targets and new methods such as combination therapy.
I think that kidney cancer is a fascinating disease, and I think that there's been an explosion of information about kidney cancer. I think that was one of the first tumors by looking at the patients with von Hippel-Lindau's disease, which is an inherited form of kidney cancer, to begin to understand the genetics and the genomic factors in kidney cancer. And that's led to the tyrosine kinase inhibitors, the mTOR inhibitors, and now, while we historically believed that kidney cancer was a tumor that can be treated by the immune system, with the checkpoint inhibitors, we see now a new, renewed interest in treating kidney cancer using immune therapies. And I think that again, cancer is a very heterogeneous and diverse disease. Just like there's heterogeneity and diversity in normal people, there is a lot of heterogeneity and diversity in cancer. And so no one approach, it's not going to be a one-size-fits-all. The goal in the future of cancer therapy is to identify biomarkers which help us predict which treatments to use, potentially even which combinations of treatments and which sequence of treatments. So it's complicated. I think that the President Obama is talking about precision medicine and putting more money into precision medicine, and absolutely, but it's not going to be so simple. There's a real significant complexity, but I think that we're much further along than we were. And again, you can't emphasize enough the importance of basic science research. One of the things that we keep coming back to with cancer is we need to understand the biology of cancer better. And as we understand the biology of cancer better, we're able to identify therapeutic targets to treat. And then ultimately, in our country, let's try to prevent cancer. And that's something that, again, by understanding the biology of the disease, potentially we can identify the triggers that turn on cancers and how to potentially alter those triggers.